Hi everyone, and welcome to Scottish Drugs Forum and Simon Community Scotland's online event for International Women's Day. I think it is probably best that I just pass over to the chair of today's event for you. I'm delighted to pass over to Dr. Aileen O'Gorman. She is Programme Leader for Contemporary Drug and Alcohol Studies at the University of West Scotland and also a board member of SDF. So thank you, Aileen.
Thanks, Leslie, and welcome to everybody who's in. But I think it's actually a fantastic achievement that we've managed to break the internet, because there has been so much interest in today's event that has been a really heartwarming feeling, that when Leslie and people in Simon community had this idea for the event, we weren't quite too sure how popular it would be, but we've had over 500 people registering, and more people will be able to see this as it's recorded and look at the event afterwards. So a very welcome to everybody who's in, and to those who will attend later and see the recording, and a happy International Women's Day to everybody. So I guess the event, I think, is really special because we rarely get the opportunity or the space to talk about women who use drugs, and we rarely get the opportunity to talk about harm reduction. So when I was asked to chair the session, I was really delighted to do that, because as a researcher in this field for many years, they're two of my favorite topics, and they're, as I said, often sidelined, I guess. So today is an opportunity to change that around, and as I said, the indicator of so many people registering is a really positive note that people are interested in these topics. So, you know, International Women's Day is about people coming together as a collective to reflect on gender inequality, but also to celebrate women and to celebrate the progress, slow though it may seem sometimes, but the progress towards having a better gender equality in our world. And we have some fantastic speakers and presentations on examples of really positive practice, particularly of working with women who use drugs and harm reduction. And I was just going to reflect very briefly on a few things to sort of set the scene for the rest of the afternoon. And I suppose traditionally, just, you know, to say that drug use is often seen as men's business, that because smaller numbers of women were either in treatment or identified as having a drug use problem, that it's largely services and policies have been orientated towards the male experience. But we've seen, particularly in the last 20 years, how the gender gap in drug use rates has really decreased and narrowed, and particularly for young women, far more young women using different substances than their male counterparts. So we do know that about a third of the estimated 60,000 problem drug users in Scotland are women, and we do know that there's been a greater increase in drug-related deaths among women. But we also know that women who use drugs are a very diverse group, but that the outcome of that drug use and substance use is very much influenced by our class and our economic status, by our race and ethnicity, by our gender identity and sexual orientation. So it's quite a diverse group for services to respond to. In responding to it, I guess the news isn't good in many senses, particularly at a policy level. So one of the things I like to do is, see how many references there are to women in different policy documents. So back to the Road to Recovery policy in 2008, there was just one reference to women. The more recent Rights, Respect and Recovery document, there were 9 references to women, so a little bit better. But women in these policy documents are often portrayed as being deviant, as being poor mothers in particularly, or people working in the sex trade. So it's a kind of unusual framing of women as people who use drugs, and something, I, in my work, try to contest against, and I'm sure many of you do too. So we do know that women's routes into drug use are quite different to men's, that the pattern of drug use is quite different, and that the health and social care needs are very different to men's. We know women who use drugs are more, and particularly at the more problematic end, are more likely to experience trauma, more likely to experience gender-based violence and poverty. And poverty is one of the big sort of contextual pieces of the outcomes of women, for women who use drugs, because you're more likely to be imprisoned if you're living in poverty. You're more likely to have your children taken into care. So there is a need for what I call gender responsive services. So services that are safe, that are trauma informed, and that address the specific needs of women. Harm reduction is a kind of ideal approach to that. And I guess, you know, policy has often focused on more recovery orientated care, which is a slightly different focus and emphasis. But harm reduction, which is something, you know, Scotland was to the forefront in the 80s and 90s in the whole of the UK and in Europe in terms of the response to the HIV epidemic at the time, and was a real world leader in harm reduction. And I guess we've lost some of the elements of that, but I know many of you working on the ground continue to work in this way. But it is about the public health approach, which our current policy is all about, a public health approach. So harm reduction is the original public health approach to drug use and related problems, and seeking to reduce the harms associated with drug use without necessarily reducing the drug use. And that can be quite a contentious issue when a lot of policy is moving towards recovery-based abstinence. But for women, and for the reasons we've outlined about the specific experiences that women have, this harm reduction approach is ideal. Just to flag with people and to remind people that, you know, the principles of harm reduction, you know, are very much about that, respecting the rights of people who use drugs, of treating people with compassion and dignity, that having a commitment to evidence about what works, and reducing, you know, the broader health, social and economic harms, particularly that women encounter, which are often more of a problem to them than their substance use. There's also a commitment to social justice and collaborating with people who use drugs, that nobody is excluded or should be excluded from health and social services that they may need, that the barriers to services should be low threshold, so that they are, you know, they are open and welcoming and inclusive. And most of all, that they avoid stigma, that work in the kind of community development sort of school of working with people where they are at in their lives, without judgment. So I think in the papers we're going to hear from our different speakers today who work at the coal face, so to speak, and harm reduction. That is, we're going to hear some really interesting examples from that. So Leslie, if you would like to gish the slides, we'll move on to our first speaker. Claire is the policy officer with the Simon community in Scotland, and Claire is going to talk about policy into practice, reducing harms in homelessness. So over to you, Claire. Thank you very much.
Thank you, Aileen. Thanks for that introduction and your presentation. And just a thank you to Scottish Drug Forum for inviting us to speak today. So so my name is Claire Longmuir. I'm the policy and practice lead for Simon Community Scotland, as Aileen has said. And today I'll be talking to you guys about policy into practice and reducing harm in homelessness, and some of our experiences of introducing and embedding harm reduction across our women's services. So for those of you who don't know us, Simon Community Scotland is Scotland's largest provider of homelessness services, and we operate across the central belt of Scotland, so in Edinburgh, Glasgow, North Lanarkshire, Perth and Dunbartonshire, and we have a range of service delivery models, including 2 multidisciplinary hubs. We have 24/7 supported accommodation services, and we have street outreach teams, housing first and visit and housing support. And I'll be focusing primarily on our 24/7 supported accommodation women's services, and particularly in Glasgow, where we've done a lot of work around harm reduction. And Simon Community's mission and vision is about combating the causes and effects of homelessness. And we employ 400 staff and volunteers across our different services, and we support up to 6,000 people in a year. And we have 6 women's only services. We've got 4 in Glasgow, as I'll talk about today. We have 1 in Edinburgh and 1 in North Lanarkshire. And the policy shift that I'll be speaking about as part of today's presentation affects all of the services across the organisation. And within Glasgow, we support 39 women across our accommodation services. So where have we been? What's really prompted us to think about harm reduction and to really build and embed harm reduction into our practice is that sadly we experienced the same escalation in drug-related deaths that we see in Scotland within our residential services. And year on year for the last 5 years, we've seen an increase in people losing their lives to preventable and avoidable drug overdoses in our services. This combined with COVID-19 really prompted us to take a big step back and think about what could we be doing to reduce the harm for people who are using drugs and living within our residential services. And Simon Community invested in a harm reduction resource. And through that, we connected with organisations across the UK. We looked at the evidence and we really thought about, what are the different models for supporting people who are experiencing homelessness and who use drugs. We know that homelessness is often a consequence of all the things that Aileen spoke about during her presentation, and more specifically for women, experiences of trauma, of things that have happened to women throughout their life, through having their children removed from their care, and a lot of loss and grief. And substances are often used as a way to manage a lot of these really difficult life circumstances. And if homelessness services are working with women who use drugs and they're living in residential services, I guess what we thought about was how do we shift our policy so that we can support people to be safe and ultimately put safety and wellness at the centre of our policies, of our practices and of our way of working. And harm reduction as a philosophy in terms of working with people without judgment, working with people with compassion and care and kindness, and giving people the information, the advice and the support that they need to make informed decisions about their life and about their health. We were part of the Drug Death Task Force report, the Drug Death Task Force group reporting on women, and that really mirrored a lot of the experiences that we were seeing in our services, a real lack of services for women, greater stigma and discrimination affecting women who use drugs, and really a real lack of services that were specifically designed for women's and women's needs. So what have we done? So over the last 18 months or so, we've really built and embedded harm reduction across our operations. We've shifted organisational policy into a high tolerant harm reduction model. Now, this was really led by the evidence around the UK of other organisations who've taken this approach and virtually eliminated drug-related deaths within their services. Now, when we operate zero tolerant models within homelessness services, it unintentionally but exponentially increases the risk for the person. You're forcing that woman to potentially use in secret, to use behind closed doors. She might be rushed because she's worried about staff walking into her room and finding her with substances. She's worried about substances being confiscated from her space. Or you're just displacing the harm. You're taking it from an environment where that woman potentially has more control over and putting it into a public space or McDonald's toilets or and that's what women told us, and I'll share a couple of the quotes that we gathered when we started talking to women about this. And it's really what harm reduction is allowing us to do is to meet women where they're at, without judgment, without expectation, without any prerequisite that they stop using or reduce their drug use in order to access support. It's very much about being central around safety and wellness and relationships. We know that a lot of drug-related harm is driven by stigma and exclusion and discrimination. And if you've experienced a lot of trauma in your life, it's really difficult to build relationships. It's difficult to build trust with services. It's difficult to build trust with professionals. And what harm reduction allows us to do is to provide women with what they need to be safe and really communicate with women that we're not there to judge, we're just there to support them and to give them the information they need to be well. Now, what high tolerant has resulted in for us is it has reduced the amount of people losing their lives to overdose within our services. In 2020, we sadly lost 11 people to drug overdoses, and in 2021, we lost 1 person. Now, we know that every drug death is a personal tragedy for that person and for their families and those who love them and cared for them. But what we're seeing from this early data, and which is reflected in evidence across the UK, is that if we take a more high tolerant harm reduction approach within homelessness, we can really reduce the harm and reduce the deaths. And ultimately that's, it's a national mission, and it's certainly a mission for us within Simon Community. And it's that ability to build relationships, like I've said, it's that ability to build trust and create spaces to have open conversations with women who use drugs and provide them with what they need to be well. And ultimately it supports our ambition in becoming a trauma-informed and psychologically aware organisation. We have ambition across the organisation to really move into this space and to understand the impact of trauma in terms of women being able to access the right care, and also recognise that as a system who's potentially caused harm or who's potentially unintentionally put barriers up or made it difficult to access, that we have to take big steps into that space to prove that we're going to try and do things a different way, and we're going to really, as Aileen says, meet women where they're at. Now, these are a couple of the quotes from women when we asked them what was their experiences were prior in other services. And the first one reading, "They didn't really do anything. They probably would have kicked me out if they knew. You would have to hide using. Here, you don't have to, as long as you're honest and straight up." The second one being, "You weren't allowed to use. You would lose your housing if you were caught. It meant I had to use in the toilets, public spaces. It's not like you can use on a public park bench or in the open." And finally, "Past has been awful because you're not allowed to use in your accommodation, but you've got to go outside and find places, in toilets, and whatever you can find, and you're almost alone most of the time. You're alone most of the time, so the staff can't keep an eye on you." I think that really highlights the impact that some of these policies can have on women who are using services. And we know that experiencing homelessness, you don't have a lot of choice. You don't have a choice over who you live with or who's within that space with you. And in terms of being trauma informed, that's something that we're really working towards across Simon Community, is giving women as much choice, as much agency, and importantly, as much voice as we can to ensure that they feel included in the conversations that we're having with them, that they feel included in decisions that are being made about their lives, ultimately. So through adopting high tolerant, it's really allowed us to embed harm reduction within our services. We wouldn't be able to do the harm reduction work that we do within a zero tolerant environment. It just wouldn't work. So across all 4 of our Glasgow Women's Services, in partnership with NHS Greater Glasgow and Clyde, and John Campbell's been an amazing support in order to get this embedded across the women's services, but we now provide injecting equipment in-house. So we provide 1 ml, 1 hit kits, 2 ml and 2 ml orange and 2 ml blue, and foil and water. And this is a 24/7 service, so women can access this whenever they need. And while obviously providing safe injecting equipment can really support women to use new equipment every time they're using drugs, but what it has really done for us has been a point of engagement. It's told women that we're kind of walking the walk as well as talking the talk, and it's really kind of helped us embed our policy ambition and our harm reduction approach. And it's just the ability to open up these conversations and also so that staff are working with their eyes wide open, that they know what's going on within the building, that women can come and let them know so that they can keep them safe, they can provide welfare checks, and they can make sure that the women's safe and intervene if there is an overdose situation. It's also allowed us to deliver conversation cafes, and I'm sure that Hannah and Jai will talk about this a little bit more during their presentation, but the conversation cafes were really just really informal spaces for women to speak about what was going on in their lives, and that might be their substance use, it might be their mental health or relationships, or a range of different things, but it was just a space that we put food on, we were based there all day, and we could have conversations around things like safe and injecting, around overdose, and it was just about trying to create that environment of safety so that women felt that they could speak about these things, because we know they're highly stigmatised, we know that they're really difficult to talk about. And what came out of that for us was that women who had potentially been in and out of services for a long time, some women we were speaking to had been in treatment for maybe 20 years, who hadn't had a conversation around safer injecting, and they learned how to use drugs through like a family member or a friend, many years ago, and didn't know some of the really basic messaging around keeping themselves safe when they were using drugs. And that prompted us to think about how else we can do that. And Hannah and Jai, my colleagues, will talk about our digital approach to harm reduction later on, and how do we connect women with the information that they need. Another thing that we've done across the organisation, we've developed a harm reduction champions network. So as I've said, we work across Edinburgh, Perth, North Lanarkshire, Glasgow and Dunbartonshire. So we have harm reduction champions based in all of those services, and it's just recognising that things are different in Edinburgh than what they are in Glasgow, and it allows us to really respond to the kind of local need. So in Edinburgh, for example, we've established safe injecting equipment again on outreach. We're working in housing first, and it's just allowing us to be quite responsive, I guess, as an organisation, and see what's coming through for people that we support and how can we respond to that in a way that meets their needs. Also, very recently, we've started introducing naloxone personalised plans. Now, again, that came from the conversation cappies and the conversations we've been having with women who have found they understand that naloxone is a life-saving medication, but their experience of having naloxone used on them can be quite difficult. And what we've done with these personalised plans is we've said that we'll always have to intervene in an emergency situation to save your life. But before we even get to that point, what can we do to make that a nicer, a better experience for you? And it allows us to talk them through, why we would use naloxone on them, and what to expect after naloxone's been used on them. And it also allows us to say, what would help you afterwards? When you do come round from an overdose and you're not feeling great, and what could we have there to make you feel better, safer? We've got someone who's got, for example, Lucozade Original in the fridge in their service, because that's what we said would really help them on the other side of that experience. So it's just about putting that trauma-informed approach into practice, and really supporting women to have that say over things that are happening to them, and health interventions that we do have to carry out within the services. I'm just going to share with you now a short clip from one of the women in our services, and she describes better than I ever could how this shift has impacted on her.
I believe there's more deaths in zero tolerance because they've got to either use before they go into the place, and the fact that they might not interact with staff as much because it's a zero tolerance, or like they could just walk past and say, "Hi, I'm fine," but by the time they get up to bed, get themselves relaxed, or even have a bath and relax their full body, and they go to bed, hopefully touch cherry wood and they've not passed away. But I believe there should be more places like where I'm at the moment, because if the staff know that the person's using, they know what drugs they're using, they know roughly about the amount and what days they're going to be using a lot more, especially when it comes to pie days and that, because I've had my life saved in here when I relapsed, and I thought that we'd been off drugs for 7 months, I thought I could still go back out and swallow the same amount of street tablets, the same amount of pre-gambling. I thought I'd be alright, and if it wasn't for the staff in here, I'd have been dead. So I believe places like this should be open more for women, and for guys as well, but for women, because it keeps them safe. If they're far too drunk or too intoxicated, the staff can basically try and talk them round and say, "No, what, how do you just stay in, have another wee?" And before they know it, the person's even too tired to argue back, and they just get back in the flat and they can go to sleep. And staff go up and do checks every 10, 15 to 20 minutes. which I know of the rules, and I believe it saves a lot more lives. But definitely there should be more places like the supported accommodation I'm in, because you've got staff 24/7 round the clock. If you feel as if you've used too much, or you don't feel too wary, you think, oh, I think I've took my breathing, you realise your breathing's gone slower and your heart's gone really, you can feel your heart actually boodle. You can just buzz straight away and say to staff, I need help, phone an ambulance, or going to just calm me down, and the staff can sit with you in your house and say to you, right, what have you took, and they can write it all down, and they can phone the paramedics and they can come out and check on you. Know what I mean? So there's definitely should be a project where there should be more places like where I'm living at the moment, because as I say, if it wasn't for the staff in here, and the woman that I'm doing an interview with, I'd be dead. So I'm thankful for this place, because the relapse that I had really opened my eyes to how my relapse isn't it, I just want to have a bit of fun. My relapse is basically told my head, I don't want to keep using drugs every day. You're just gonna use a couple of days until you're dead, and that's what it done. You know, it killed me 4 times, and as I say, thank the heavenly God, and I repented, whatever. And I'm getting back on track, so I definitely should be more places like this, because there's too many people dying in the other places, especially when there's couples. See, when you've got like B&Bs and that, no drugs, no this and that. The no drugs and that go along the place as soon as you get caught, kicked out. What's that going to cause? What, they're just going to be back out in the street and they'll use it there and die out there?
I just want to say thank yous for that woman for sharing her experience. Now, alongside our policy shift and embedding harm reduction, the support that we put in for our teams has been around the training support we put into teams. All of the staff within Simon Community go through an impact training, which is really about trauma-informed practice, relationships, psychologically informed environments, and also how the impact of trauma impacts on women's ability and people's ability to interact with services. We've also, through that training, introduced an introduction to harm reduction training for all of our staff coming through the organisation. We talk about why it's important to us in relation to being embedded within social justice and human rights, and really working with people with dignity and compassion, and how that fits in with our values and our ethos as an organisation. As I've said, we've created a harm reduction champions network, and we meet once a month as a network to talk about the things that are coming up for us within our practice, how we can respond to that. We've also created and we're rolling out medical assisted treatment standards awareness training. Now we know that obviously the medical assisted treatment standards, which I've not spelled correctly in those slides, apologies, are something that's really going to shift practice, or the ambition is it's really going to shift things for people that use drugs in terms of access and support and flexibility. And we're looking about how can we support the implementation of those standards. Now that's important for our workforce, but we're also communicating with the people that we support. And letting women know what these standards are and what their rights are associated with these standards. We've been working with women to write down their own agendas before they go into meetings, for examples, and sharing that through our digital project, linking them in with an email address so that they can be part of those conversations. And we found that's been a really effective way in terms of bringing women into that space and ensuring that they're central to what kind of being spoken about and the decisions that are being made about their lives. There's some really powerful stories associated with that, as you can imagine. Women telling us that she didn't even know she had rights as a woman that used drugs. And so I think that how important it is, especially for us within homelessness services, or I can talk to that area about really ensuring that people know what these standards are and what our responsibilities are within services to make sure that these are promoted and pushed through for the people that we support and that we work with. And we've worked closely with Scottish Drug Forum, who've been an amazing support to us. They've came in and delivered conversation cafes with us. Thanks very much, Lynn and Jill, if you're anywhere in this webinar. And we've done whole services naloxone training, which has been really useful as well. And like I say, harm reduction fits in with our ambition about supporting people with kindness. I think one of the things that I often find really difficult is that common kindness can seem extraordinary. for people that use drugs and women that use drugs. And you know, it's just about what harm reduction allows us to do is just central everything around that kindness, compassion and care. Now, these are just some quotes from our staff in our services around the policy and around the training. So I'll read the two big ones, if that's okay, and I'll leave the big one in the middle. I feel the new policy has made some things clearer around drug and alcohol use in the service, such as what is classed as illegal and what is classed as dealing or sharing drugs. I agree the safety first approach and harm reduction approach is a positive step forward in reducing overdoses, spread of infections, reducing infections in injection sites and promoting an inclusive organisation for people who actively use drugs, substances or alcohol and use our services. And one on our training. So it has consolidated my thoughts around drugs, mental health, physical health and the intersection of them all. I found it really encouraging and it's a subject which, along with mental health, I feel so passionate about discussing openly. Raved about the training to my colleagues and I hope that it will mean I'm even more confident in talking to women about their drug use honestly and without judgment. The training makes me think of the phrase radical compassion, which is a philosophy I strive to follow through my life. It's one of my favourite feedbacks. I love that idea of radical compassion, radical kindness. Next slide, please, Leslie. So what's next for us within Simon Community? So we are developing alongside our policy a series of best practice guides to really support the development of our policy. So things like best practice guide in relation to delivering safe injected equipment, for example, without judgment, and really encouraging people to take as much equipment as they need. And how do we deliver that service with that kind of kindness and compassion at the central. We've just very recently employed clinical psychologists to support our harm reduction trauma-informed approach that will be based within our women's services to really help us move from being trauma-informed into trauma-responsive. We've launched our By My Side app, which Hannah and Jai will speak about a little bit later, which is part of our digital approach to harm reduction. We're working with international colleagues to reflect, enhance and improve our approaches to harm reduction. Like, we are absolutely on a learning journey here and we're learning all the time from the people that we support, and we're just trying to, you know, respond to things as they present. You know, like for example, like we're seeing in Glasgow for the first time a lot more injecting cocaine use, so we're just trying to kind of ensure that we are responding to the needs of the people and the needs of the women who are living in our services. We've partnered with Cresa in Portugal to share best practice, and we're looking at staff exchanges this year. And we're looking to share our vision and leadership development with our senior staff, just to have that really shared approach and application of our values and supporting our teams to move into this high tolerance space. And we're also looking at creating peer pathways into employment. We recognise that the pathways out of poverty is often employment and education, and we're looking about where we can provide some of these opportunities for the women in our services. We've seen through a digital approach to harm reduction just the absolute power in giving women a safe space to share what's going on for them. And you know, they could absolutely write a book on how to and how not to run services. So I think it's just so important how to ensure that we're building on some of that learning and taking that kind of co-production community response forward. And we're creating unique and specific services for women who use drugs that provide a wraparound service that will be starting in Glasgow, a service that will be specifically for women. Yeah, so that's what's next for us for the next little while. And that's me. Thank you all so much for your attention and for listening, and I look forward to the question and answer.
Thank you, Clara. Thanks a million. That was fantastic. And just an exact example of what I had been talking about earlier about how do we integrate the principles of harm reduction to services. And just, I really like that idea of high tolerance harm reduction is fantastic. Great. So thank you very much. So I'll hand over to Professor Catriona Matheson from the University of Stirling, which most of you will know from her research and her work in the Drugs Death Task Force. And Catriona is going to talk about a research study she conducted with the Scottish Drugs Forum about vulnerability and risk for women who, I beg your pardon, yes, for women who use drugs and are engaged in transactional sex. So take it away, Catriona.
Thank you very much, Aileen. I'm really pleased to be part of this webinar and allow us some focus on, you know, how we can support our most vulnerable women and the importance of harm reduction in doing that. So this work, I want to share some research findings with you today. I'll be a quick run through really. This work was led by Scottish Drugs Forum. I was working with them in a freelance capacity, and I want to acknowledge the team who are listed at the on the slide there: Adrian, Leslie, Louise and Katie from SCF, who supported this work and did a lot of the hard work of the data collection work. So in case you don't get enough information just now, there's 2 reports you can look at, one on SDF's website, one listed on the left, and there's also an academic publication just out which focuses more on this particular group that we are talking about today, and that is women who are involved in transactional sex and also use drugs. Now, transactional sex, before I go into the background, just to be clear, that's the exchange of sex for goods, which might be drugs, might be something else, or money. So just we use that broader, more inclusive term. So some background to why this is needed. Obviously, you're very well aware of the high level of drug-related deaths that we have, and these increased more rapidly in older women more recently. And an analysis of this by Emily Tweed has identified that we do have an ageing cohort of women that are using high-risk drug use. There's comorbidities, and that can include mental health problems. There's challenges with parenting roles and child removal, which of course is stigmatizing and affects how people engage with services, and social security changes. And all of these have contributed to drug-related deaths in women. If you're also involved in transactional sex, you then have this additional aspect that needs to be considered. Now, very little research in Scotland has been done in women who are working in the transactional sex area since the 1990s, so this work was really long overdue. So we were interested in how prepared services are across both sexual health and drug services. And the aim of the work was to identify information, support and treatment needs associated with drug use and with sexual health and with bloodborne virus risk-taking behaviours. And the aim of this is to inform a training programme that Scottish Drugs Forum have developed and are now rolling out. So the methods, very quickly, won't bore you too much with this, but we worked across 4 NHS areas, got all the kind of ethical approvals that were required to work with NHS services. These were sexual and reproductive health clinics, injecting equipment providers, and a couple of services that specialised in supporting women involved in transactional sex support. This is briefly our participants. Now, it wasn't just women that we were initially looking to engage in the research. We also were looking for men, but as it happens, that proved very difficult. So we had 15 women and 1 man in our final kind of report, if you like. The findings today just relate to our 15 women. So this gives you a bit of a breakdown. You can scan that and see the range, but the age range was from 24 to 51, which is quite typical of women in this who are involved in drug use and more broadly in transactional sex as well. So the key themes that we were interested in and we explored through our interviews are listed on the left there. So initiation into sex and into drug use, harms associated with drugs and sex, and information and support needs. Now, when we explored these themes, there were some cross-cutting themes that emerged very strongly around control and coercion, around shame, and the key topic of focus today, that of vulnerability. So you'll see some of that coming through as I describe some of the findings to you now. I'm not going to read out all the quotes as I go through today because it's just not really time to do that, but we asked all our participants about their first experience of transactional sex. And age at this first took place ranged from 14 from somebody who was in care, and that is the quote here down in the bottom right hand corner. But also it ranged up to 34 years for somebody who had experienced mental health problems as a result of losing a partner. So other people found themselves involved from a place of vulnerability, which could be desperation for money, not wanting to be caught shoplifting or selling drugs, because they might end up in prison, and they rationalised really that selling sex was a better option. Other vulnerabilities were from being made homeless, from losing a partner and trauma that goes along with that, and mental health problems, as already mentioned. Now, drugs and alcohol could be used very deliberately to make it easier to take part in transactional sex, to take part in sexual acts, and to block out feelings of shame that go along with that. So sometimes initiation into transactional sex and drug use coincide. And this quote here is an example of exactly that. What you'll see from this is that other women may well often be involved in drug initiation. It might be a friend or some other person who's helping them, steer them into that area of work to get money. And you'll see from this quote here the feelings of shame and fear that went along with that first initial experience. So this woman described feeling scared and a bit dirty, and afterwards she certainly did describe feeling dirty. So you will see there's some of the kind of vulnerabilities coming through and the feelings of shame. If we talk about the drugs that people were using and the drug harms that can go along with that, there was a very broad range of drugs mentioned. Polydrug use was very common. You'll see the quote here of somebody describing both a mixture of prescribed and street drugs that they used, and quite a hefty combination of the sedative substances. Also high doses of drugs, people describing very high intake of street Valium, for example. And what also came across is that for some women who were injecting, this initiation into injecting, very often people said that they did share or had shared equipment before, so there's that risk of bloodborne virus, and there was an understanding that sharing equipment did bring that. But also injecting, of course, brings with it other risks around injecting injuries, and people who initiated others into injecting were not always very skilled at doing so, and people did describe scarring and a whole range of injuries that might require hospitalisation. Also, there was harms associated with sharing of crack pipes, skin infections around the mouth and scab that might be evident in scabbing. So bloodborne virus was clearly evident in our sample. At least 5 said that they had hepatitis C and 1 had hepatitis B. So the harms are evident there. So when it came to sexual health harms, participants were asked about condom use and about contraception, as well as testing for sexually transmitted infections through sexual health checkups, for example. Now, intermittent condom use was really described. So most people said that they use condoms, but not with every client and not all of the time. And for example, some clients would exert pressure or coercion, as it's called, condom coercion as a kind of term in the academic world, but by saying that, for example, they were allergic to latex. Some women also described clients using force and violence in order to avoid condom use, and this did include women who'd been subjected to rape. So the trauma that brings can't be underestimated. In terms of sexual health information, there was certainly baseline knowledge, very clear about the importance of condom use to protect against bloodborne virus and unwanted pregnancy. But there was probably less understanding of the need to have regular smear tests, for example, to protect against cervical cancer.
I think I missed.
So for some reason, my phone's having a wee chat. So you'll see the quote on the left-hand side. This was of someone just saying, look, they hadn't really been for many smear tests in their full life. They were bad for not going to them. And then on the topic of sexual health testing and screening, when the researcher asked about that, someone saying, I just don't really feel I would have a reason to do that. So we asked about service needs, and this was really came across the importance of positive relationships, and we just had Claire describing how hard services are working to really embed that in the current services from the Simon community in particular. So the importance of a positive relationship with staff was mentioned really by several participants, and changes in staff could undermine the development of what really needs to be a meaningful therapeutic relationship. And that first quote on the top right hand side here illustrates exactly that point. And another thing is really about trust and establishing trust. And so the second quote at the bottom here is, you know, if you say you're going to do something, just do it, because that's trust, and that is so important to being able to move forward in a meaningful way with people. Now, the information skills needs, where if I haven't got time to go into these, the first three you'll see are probably as expected. There's definitely a thirst for drug information, definitely a need for safer injecting practice information, and encouragement around sexual health information, including both STIs and bloodborne virus, condom use and smear tests. However, what is interesting, I want to just draw out as well, that came out was a more of a skills base, I suppose, rather than necessarily information, but how to manage difficult behaviour. How can women in this position themselves manage challenging behaviour in others? And that might be clients, and it might be other people who take advantage of women's vulnerabilities. So I think that's something we can consider in developing our skills to help enable women to cope with their situations. So to summarise, if we, I hope we've briefly been able to help understand some of the experienced risk of this vulnerable group. And it's very important in doing so to understand the emotional response as well that people feel, the vulnerability, the probably experience of coercion, control, and certainly feelings at some point of shame and possibly fear. Because what's crucial to that is how they then engage with services and that experience. So our services do need to be trauma aware. We need to work towards that, as well as providing these information and support needs. But key, very key to all of this is this non-judgmental aspect, which is fundamental to harm reduction. And so through that, we'll be able to build meaningful and trusting relationships and work with people for their benefit. I'll finish there. That's my quick run through. So I'd be happy just to look forward to any questions at the end of the.
Thank you, Catriona. That's great to have that. So our next speaker, I'd like to welcome our next speaker, Alison Scott, who's so a nice link from Catriona's work. Alison is a consultant gynecologist in sexual health, and she's going to talk to us about the Women's Health Plan for Scotland. Thank you, Alison.
Thanks, Aileen. So I'm really delighted that you've asked me to come along. I love these events where it's like we're all part of the same kind of army. I know that's not a good word to use at the moment, but we're all here and we're all got the same agenda to try and help the same group of people. So I'm a gynecologist. I set up a service for women about 15 years ago, women who are socially excluded, who have issues with substance use, are homeless, have been involved in criminal justice, and women involved in prostitution. And about 2 years ago, I was asked by Cath Calderwood, who at that point was the CMO, if I'd be involved in development of the Women's Health Plan, which was a really exciting project to be involved in. It started just at the time the pandemic hit, which was very unfortunate because we had to do everything. We actually did a lot of it by teleconference. You know, we're now so used to online, but at that point we weren't used to online. So the easiest way was for us to do it on the phone. And I chaired the group looking at sexual health for women. The people on my group were a mixture of policy and policy leads and a lot of people at the coalface. And they were all really passionate. We had a GP there who was literally 2 weeks since she'd had her baby, and she's there because she was so determined to input and to try and improve things for women. So hopefully what this will lead to is changes and benefits for women in the way they can access health. And throughout this, I was really keen to keep the voices of the women that all of us on this call deal with every day alive. The Women's Health Plan had come from a number of parliamentary groups raising questions about women's health and about gender inequality. As you may know, the First Minister has a National Advisory Council on Women and Girls, and they had spotlighted gender inequality in April 2019. The Royal College of Obstetricians and Gynecologists, which is kind of my professional governing body, produced this amazing report about how healthcare could be better for women in December 2019. And it's an amazing report, but it is vast. And sadly, nothing has really come of that. Nothing's happened with that report in England. They have recently set up a women's health strategy, but lots of things have been lost, I think, because it was too big. The British Heart Foundation published a report called Bias in Biology, which shows that women are actually 3 times more likely to die of heart disease than of breast cancer. And I think most of us probably aren't aware of that. So they wanted something about heart disease. And again, heart disease is a risk for the women we're dealing with who use drugs. They were looking to National Performance Framework and to the UN Sustainable Development Goals. And the UK government, as I say, had a commitment to a women's health strategy, which they have now set up, but which looks quite a bit different to the Scottish one. The First Minister, as you know, for her 50th birthday, did an interview with a good friend of mine, Danny Garavelli, where she spoke about not knowing about the menopause. And it's interesting because colleagues who work in the menopause say there is so much information out there for women, and yet, you know, the First Minister herself is saying she doesn't really know quite what to expect. And I think that's a bit because there's a bit of exaggeration about how dreadful it is. It is awful for some women, but a lot of women manage fine. So she was very keen that there was a lot of focus on menopause. Other politicians were very keen there was a lot of focus on endometriosis. I was very keen there was a lot of focus on stuff for women who struggle to just access the day-to-day healthcare that we all need. So this is the kind of logo which we came up with, and we've tried to make it a journey of women through life and utilising opportunities. There is going to be a huge culture change for healthcare staff who are going to have to look at all the opportunities. So, for example, if a woman attends for a cervical smear, rather than, you know, just do the smear, off you go, actually broadening that conversation to, you know, are you thinking of having children? And, you know, do you know about pre-pregnancy care? Have you got contraception on board? And really importantly, what's going on for you at home? Do you feel safe at home? How are things at home? And just opening up these conversations that health is a safe space to disclose things that are troubling you. This is quite a busy slide. It's got lots of stuff on it, facts and figures. We know that 51% of the population in Scotland are female. We know that women living in areas of deprivation are far more likely to die than those living in affluent areas. That's, you know, pretty straightforward stuff, but actually that women have 25 more years of good health if you live in an affluent area. I think that in 2022 is a pretty shocking statistic. I'm going to rattle through this fairly quickly, try and catch up some time. I don't want to overwhelm you with just the facts and figures. The Programme for Government, which is the equivalent of the Queen's Speech in Scotland, brought out these sort of 5 areas about ensuring women have access to specialist menopause services. That doesn't mean that all women need specialist menopause service, but those who do can get to specialist menopause service, and also that every primary care, every GP surgery has somebody who has an interest in menopause. As particularly, it's an issue for lots of women, but I work with women with HIV. They find it very traumatic going through the menopause because the flushes and sweats can trigger for them when they were seroconverting to HIV. It's the same kind of night sweats and things that they're getting. Approving access to women who have endometriosis To be honest, we felt that was quite narrow, and we broadened that out to women who have problems with their periods. Endometriosis is horrendous, but it's a small proportion of women who have endometriosis compared to all the women who present with difficulties with periods and pain and bleeding. Improving access to information for girls and women, and being aware that not everybody has digital access. You can have a great website, but actually, if you've not got a smartphone or a laptop, that information is therefore not available to you. And improving access to abortion and contraception services, and reducing health inequalities with women's general health, including cardiac health. Now, as I say, this all started right bang on when we went into lockdown. And COVID has actually given us lots of benefits in developing this plan. Lots of things which we've been trying to do in healthcare for a very long time, but were stopped from doing because of red tape, like phone consultations for women seeking abortion. We'd never been able to do that, but suddenly it was possible because of COVID when people couldn't come into healthcare settings. For the majority of women, there's no need to go into a healthcare setting for an abortion, and we've done evaluations that it's safe. Not everybody needs a scan, nobody needs a blood test unless they have another health condition, and women can be counselled over the phone about an abortion, and then arrangements be made for that. So using video consultations and phone consultations has become part of our routine, and we've now proved that it works, which has been great from the point of view of the Women's Health Plan and going forward and trying to have more options. So rather than making people come to appointments, we're looking at what can we provide that suits the person rather than suits the service. The way that it was done was there was a women's health group chaired then by the interim deputy CMO after Kath left her post. There were lots of policy areas involved, and we had 5 subgroups. So I chaired the one on contraception, abortion, sexual health, and we included pre-pregnancy care, because that's an area which lots of women don't know much about. Menopause and menstrual health was chaired by Heather Curry, who's a consultant in Dumfries and Galloway. So again, she's aware of issues for women living in rural areas. Women's heart health was chaired by Maggie Simpson, who's an advanced nurse practitioner, now retraining to be a doctor. We had a group of women who contributed to lived experience through the Alliance organisation. And then there was a group which really, I think, has enriched the whole writing of this document on gender and health and on health inequalities, intersectionality, which is, you've got health inequalities because you live in an area of deprivation and because you're female and you've got caring responsibilities. You can also add into that if you're BAME or from a different sexual group, then all these things add up as multiple barriers to you accessing healthcare. Once we'd come up with some actions, these were then put to the lived experience group, both as a survey and in workshops to see what they thought of our outcomes. So the remits were to look at gaps in service and consider areas of best practice and look at practical solutions. One solution that isn't going to work for all areas. So if you're living in a remote and rural area and you've got a substance misuse problem, you might not want to go to your local pharmacy because you're seen and known, and so we need to think creatively and out of the box of how we can accommodate people from all different areas with all different needs, but very much moving away from expecting patients generally, and women in particular, to come to a centre. If somebody's living in an area of deprivation, which is generally on the outskirts of a city, and they have to go to the centre to get help, that's really impossible. I, at one point in my life, had 4 children under the age of 7. If somebody had asked me to get 2 buses with a lot of them to go and get my cervical screening done, it just wouldn't have happened, or I would have probably killed one of them by the time we got there and got back again. So we have to take the services out to where women are. It involves linking across policy areas of government such as health inequalities, justice, all these different areas are involved in it. And we need to make sure that women's voices are heard and representative women's voices are heard. particularly, you know, reflecting on what Catriona's just said about transactional sex. That is such a polarised discussion, and there are some women with very loud voices, but they do not represent the majority of women who are involved in transactional sex. We need to be cogent of these kind of issues. So this is the kind of main slide. I'm hoping you can all read this. The ambitions, which were cross-cutting across all the groups, were that healthcare for women is holistic, respectful, and individualised. That women will be provided with consistent, reliable, accessible information to empower them to make informed decisions. That all professionals involved in delivering health and social care will work closely together to improve care for women. And this bit, the yellow bit, is the bit that I bang on about all the time. Healthcare for women with complex needs, including those with additional support requirements for social issues, will be delivered innovatively, including jointly with third sector support agencies. When I set up my clinic years ago, it was very clear that although I was coming at this from, you know, the women we were seeing were very much at risk of unintended pregnancies, STIs and bloodborne viruses, that wasn't the women's priority. You know, the women's priority was things like a roof over their head. And so it was only by working with Another Way, who are part of SACRO, that we could address these needs. And once we'd done that, then the women would engage with health. And that partnership working is vital. And it's something that health tends to stick in a silo. We're a bit scared of coming out. And I keep saying to people, actually, it's much more interesting if you get involved with organisations like SDF and Simon Community and Social Bite and SACRO. You know, it enriches your practice and you achieve so much more. So the principles of the Women's Health Plan are very much to address inequalities, to look at gender equality and intersectionality, and to look at women as a journey through their lives, not as a single occasion where a woman attends and we have an opportunity to deal with our health and well-being, and that we are respectful and inclusive in the services we provide. So this is a sort of life course approach. So looking at with young girls in school, looking at relationships, RSHP is the sort of gold star education project, periods and then menopause as we go on. And that, just as I said before, all the different aspects that overlap to impact a woman's health. So we developed these in subgroups, as I've said, and we've developed short-term, medium-term and long-term actions, and these have already started. Many of them are underway, and the implementation work is now starting. We want to empower women and enhance the education of the health and social care workforce and create data. Often data is not even separated by sex and gender, so we can't see what the differences are between men and women. So these are the groups who are involved, and this is where we're at just now, is with the implementation plan. So that's the end of my talk. Thank you very much for listening, and I'm very happy to take questions at the Q&A section. Thanks, Aileen.
Thank you very much, Alison. And I just invite our speakers from this morning to show their videos. So Claire presented from the Simon community's perspective, Catriona Matheson on women engaged in transactional sex, and then Alison on the Women's Health Plan.
Yeah,
Thanks,
we have a couple of questions in already. So the first one that I saw that Catriona has begun to respond to, but working in harm reduction, there's a question here on why crack pipes aren't more readily available for women who use drugs. So over to you guys.
Okay, do you want to feed through a few questions, or?
There's two questions there at the moment. So there's that one, and then there's another one in that's asking about evidence shows that menopausal symptoms are similar to drug withdrawals. Any plans to develop training for practitioners supporting women who are using substances? Okay.
So Catriona, you probably know more about the crack pipe situation from your time on the Drugs Death Task Force. So would you like to?
Yeah. Yes, so crack pipes, unfortunately, it's a wee bit questionable, but they generally do count as paraphernalia, drug paraphernalia, or equipment used in the preparation of or administration of illicit drugs. And that's me using the legalistic jargon. So that means, unfortunately, that they can be controlled under the Misuse of Drugs Act. And so, you know, that's why services are reluctant to distribute them, because in theory, that could be an illegal activity under the current legislation. There's possible ways around that, but that's the bottom line.
Okay. So in my days in working down south in England, crack pipes were available, and I know they're available in Ireland as well, my country of origin. And they have similar Misuse of Drugs Act. So I guess that's something to think about how we can introduce those, you know, that it might not necessarily be breaking the law, but slightly a soft break of the law, if that's possible.
Yeah, well, I know that's, and it's down to interpretation, isn't it? But that
yes.
and how and policing.
Yeah.
All of these things, but
we have our police on board when the lock's on, so we might get them on board with this now. So Claire, there was a question for you, which I think is about how to bring staff along. And I guess this, you know, you probably speak from the Simon community's perspective, but I think it probably is relevant to everybody about the high tolerance harm reduction approach. About what was your experience of bringing staff along with you for that vision? Was there a difficulty? Was there a way of persuading people? Did it take much persuasion?
Yeah, thank you, Aileen. That's a great question. Yeah, so the answer to that question is yeah, there were definite points of difficulty in bringing staff with us along in that journey. It was quite a shift, as you can imagine, going from a zero tolerant environment into a high tolerant environment. What was useful for us is that we weren't the first organisation to adopt this model, and we linked into organisations in Northern Ireland and Wales and Cornwall who have all adopted high tolerance for a long time. We also worked alongside Kevin Fleming, who's a consultant around you know, high tolerant models for working with people who use drugs. So there was an evidence base there, and I think it was really, in promoting high tolerance, you can reduce drug deaths, and that, you know, that's something everybody can get on board with ultimately. And I think, you know, the high tolerant harm reduction model very much aligns with our values in terms of person-centered care, working with compassion and kindness. So while it was initially quite difficult at times, I think when you present it in a way that people can really get on board with, in terms of working alongside the people that were there to support it, it becomes an easier way of looking at it. I think there was just fear around it would cause more harm, or, you know, it would result in more people losing their lives to overdose, when in fact we saw the complete opposite.
Yeah, excellent. And that's a really good example, I think, of that kind of networking and building networks across organizations. And I know SDF do a lot of good work in that field of bringing people together to share those kind of positive experiences. So that's, I think, a really good example of how we might address some of those issues. And I see there's a question about April. April Shaw's asked about women, menopausal women, and that often the symptoms of menopause are very similar to withdrawal symptoms for drugs. And were there any kind of good practice around how we work with women on those issues? I think, Alison, you might have some input for us on that from your work.
Yeah, I've put something in the chat, but yeah, I mean, it is possible for substance misuse staff to do sexual health training. We've trained up a few staff in Lothian, so they can talk to women about contraception and sexual health and menopause. But we also offer a training program, and I'm hoping that will be available on Atira, which is open to anyone. And that is, again, part of the Women's Health Plan. It's about education of workers so they can talk to women about their health. So just sharing knowledge. And it's also about education of healthcare workers about substance misuse as well, because it works both ways, that, you know, healthcare workers often don't understand the issues around substance misuse for women. So they need training on that as well.
Great, thanks, Alison. Thank you. Leslie, you're keeping an eye there on the chats? How?
Yep, we've got a new one coming in. What is a key feature of making high tolerance environments safe, Claire? Don't Actually, Claire looks like she's frozen. So I don't know if anyone else has any thoughts on that question.
Sorry, might have been dodgy there. Can everyone hear me okay?
Yeah.
Yeah.
So the key features in making a high tolerant environment safe, I guess it's, these things have always, so people in our services, there's always been drug use. So in fact, by bringing things out into a space where people can talk about these things in a more open way, actually, what we've found anyways is that it drastically reduces the harm, because you're not working with your eyes closed, you're working with your eyes wide open, you know, and you're really supporting relationships and ensuring that people can talk about what's going on in their life, and you can respond in an overdose situation. Obviously, we have legal responsibilities, so there's things that we cannot tolerate because of the Misuse of Drugs Act. But what we've found anyways in adopting this type of approach, it actually makes things a lot safer, and the relationships with the people that we support just take on a completely different meaning, because people can just talk about what's actually going on as opposed to have to keep things secret and hidden. And we know that when things are hidden, they're often much more harmful for the person that's living in the services, and ultimately for the staff as well, because they don't know what's actually really going on.
Yeah, I think that's a really good idea. And I guess the idea that high tolerance doesn't necessarily mean that it's not organized and they aren't safety and boundaries put around that and staff trained to work in that particular environment. So I guess high tolerance doesn't mean that everything goes, you know, everything is on, but it does mean that people are safer. And I think the examples you gave on the reduction in overdoses in your services was a real indicator of that, of how that works when it's done well. So Leslie, there was the kind of what would I call it? The recurring question every International Women's Day is, what about the men?
The question is, does anyone have a positive response to any workers who do not see the need for International Women's Day? So many times I've heard, what about men?
And I think that probably transfers to services as well. So if you have gender responsive services for women, we often get the reply about, well, what about the men? So, well, as my response to International Women's Day and people critiquing it is that, well, every other day is Men's Day. So we need at least one day when the focus is on women. So even though that's a bit flippant, I think the evidence backs us up that it is still a man's world that we live in. And as we see, you know, most of the services are planned and developed for the male experience as men who use drugs. So there's time, as we could certainly see from all the needs that were identified by our speakers, the complex needs for women, which are different and need to be addressed differently. So that's a question, I guess, that we're always.
And in the chat, we've just been informed International Men's Day is November 19th.
Oh, they only have one. I thought the other 364 were. Anyhow, so any other questions? Or I suppose we're trying to make up a little bit for time.
There are questions coming in, but I suggest that we hold off to the end of the Q&A, okay, the next Q&A session, which is a bit longer, and move into the discussion rooms yes, at this stage.
Welcome back, first of all, to everybody, and we're going to continue on with two more wonderful speakers. So we first have Hannah Boyle and Jai from Simon Communities Scotland, who are going to talk about For Women, by Women, co-producing digital harm reduction resources for women who use drugs. Thank you, Hannah.
Today, I just really want to share some of the incredible work that we've been doing at Simon Community Scotland. And you heard a little bit about our move into high tolerance and our harm reduction approach within the organisation from Claire this morning. And really what I've been working on with the women that we support in our residential services is looking at how we can use digital and combine it with our harm reduction approach to create resources for women who use drugs. So where did the digital approach to harm reduction come from? Well, this really began from the development of our harm reduction policy and our move from zero tolerance towards high tolerance within our supported accommodation residential services. And we carried out a series of conversation cafes within our women's residential services, really involving the women in the conversations about what the policy would look like, what they want the policy to be, and how we can better support the women with their drug use. And from these conversations, we were really having the open, honest, transparent conversations with women about their drug use, and allowing the relationships that we had with the women to really grow in a positive way, where there was no fear of judgment or discrimination or stigma towards them for using drugs, and the staff were there to support them regardless. So through that work that we were carrying out and developing our policy and bringing the women alongside us, we really opened up this space of co-production and co-design, and how when we allow and when we bring the people that we are directly supporting and who are affected by the policies and the decisions that we make, if we bring them into that space with us and make it a collaborative process, how we can look at the different outcomes and positive outcomes that we can achieve for everyone. And moving forward in Simon Community, digital and harm reduction are two key strategic visions that we have. And within this project, we've been looking at how we can use the work that we've been doing with Get Digital Scotland to get people digitally to work on digital inclusion and get people connected, and how we can help the women in our services to use digital and access resources and information that might help them stay safe, live well, become more informed and empowered within their day-to-day lives. And what all of the digital and harm reduction work we've been doing has really shown us is that there's a lack of resources made by women who use drugs, made by people who use drugs, and a lot of the resources that exist might not meet the needs of the people that we support, as often they are geared towards professionals working within the field, or they're maybe not made through a gendered lens, and this doesn't take into account any of the unique barriers that women face. So this project really looks at co-production and how we can work together at Simon Community Scotland with the women that we support to create these resources, make sure that they have their say and their place in creating resources that they would find beneficial. So that digital harm reduction approach has 4 different methods. So we provide each woman with a digital device. For 12 months, she has unlimited connectivity to the internet, so that she doesn't have to choose between what she uses our internet access for. You know, she's got unlimited connectivity to give her a real wealth of opportunity to go online and use the internet for what she needs to use it for. We also have combined our harm reduction approach and this co-production approach. So looking at harm reduction through the lens of how can we bring the women that we support, get them involved in our policy and help to create resources that they would find beneficial. So this is seen as really putting the women at the heart of our approach, and you know, walking alongside them on their support journey with us, but bringing them in to be involved in a project that they will benefit from as well. So we've seen 55 digital devices and unlimited connectivity to women living in our residential services go out over the past 6 months, and this project's going to be extended for 6 months from now, so we'll hopefully see a lot more devices going out, a lot more women digitally connected, able to access all of the benefits of the digital world. We also have a key cohort of women who are continuously involved in the project. And when we talk about co-production and co-design, we really mean that the women are valued for their time. So this value, you know, we make sure that we pay the women so that they truly feel valued for the expertise and everything that they're bringing to the project. And from that, we've seen a real shift in how the women have seen themselves being involved in the project, and a real growth of confidence in what they can offer. Because we know that the women we support and women we work with, they are experts of their own experience, and what this project does is it lets them share their voice and share their expertise in a way that works for them. So within the work that we're doing, we're carrying out design labs, and these are workshops where we, the 3 hours long, the women are paid for their time to come along, look at existing harm reduction resources and look at how these could be better. And when the really interesting thing is when we kind of sowed the seeds for this project in the very beginning, we believed that the resources that we were going to make would be really educational, informative videos about safer injecting, about wound care, about overdose awareness, all of these things that, you know, women who maybe have been using drugs for a long time didn't have the knowledge or the information about. But really what's coming out of the space and what the women are wanting to create is these kind of narrative journeys. You know, they want to share their story in a way that works for them. So what we maybe thought we were going to create has now changed, but still focusing on, you know, we've got that range of resources that hopefully will help all women who use drugs across the world, but really looking at how we can platform the women's voices in a way that works for them. So we have some TikTok videos, we have some podcasts, and really the podcasts have been the most popular, and I guess that really just gives the opportunity for the women to talk about what they want to talk about in a way that means that they have total control and ownership over their story in a way that they might not have before. We know that when the women that we support, you know, have to tell their story continuously to services when seeking support, but this gives them the opportunity to share what they want to share with the world, and you know, and to help other women through that. So it's just some pictures of the digital inclusion work and a digital approach to harm reduction in action within our services. So I've just talked a little bit about these resources and the opportunity for the women to share in their story in a way that works for them. And we've also got these TikTok style videos, and these 2 distinct key categories of resources for women who use drugs, made by women who use drugs. So we have, you know, these educational and informative videos that maybe focus on specific topics, like we have videos about hepatitis C and the differences in treatment, you know, from the past methods of treatment now to treatment as it is today. But then we also have, you know, real emotional, thought-provoking stories of women who are sharing their experiences of services and a lot of system failure, and where the services have let them down and where the system has failed them, and where they think that they, you know, they could help other women by sharing what they've experienced. And just as I said before, the women having full control over the content and how to present their insight and expertise. And the important thing for me is that, you know, we're continuously going back to the women with these resources, so they will hopefully, you know, be hosted and help so many other women across the world. But if we go back to the women and they feel they don't want to share these resources, and maybe something's changed for them, that they've got full control over that. And just making it a real co-productive approach, so that the women are always in control of that. And I guess just some key learning from the project. The importance of relationships has been such a key thing. You know, from getting to a stage where the women want to create these resources, you have to build up that kind of relationship where they feel safe, they feel secure, and what they're sharing. And you know, we believed that these resources were going to be really factual and helping to share that kind of immediate knowledge to women who might need it. But really what the women are wanting to share is something that, you know, takes a wee while for them to really build up to letting that go. And what I've found has been really amazing is a lot of the women are describing this kind of sense of catharsis and this kind of release, and almost that by sharing their story, it's a little bit of a therapeutic release for them. We're really learning that there's a lot of shared challenges faced by women. So, you know, where women were potentially want to talk about drug use, it's all coming back to the same key shared challenges that they face. So domestic violence, loss of children, lack of support from services, poverty, sexual violence. You know, it's these key range of issues that the women we support have faced. I've mentioned this a little bit before, but what we're really seeing is that there's a real sense of confidence and empowerment coming out from being involved in this project. And really what we're learning is that the women involved in the project, you know, want to be involved in something like this, where they they're really using their expertise and their knowledge and their experiences to help others and to use the skills that they've got in that way. And every single one of the women that has created a resource has come back and said, if this helps one person, that's all that matters to me. And we've really seen that the engagement has been incredible with the women being paid for their time, but also women saying, I would do this for free, I don't want to be paid for my time. But what makes such a really amazing project is that the women are valued, are truly valued. And just again, highlighting the need for more opportunities for meaningful engagement, and that the women the women we support, they have these incredible skills and you know, so much knowledge and awareness, and by providing this project within our services, we can get them involved in that. So I've talked a little bit about the resources, but within the work that we're doing, we've also been developing an app alongside the women we support, and this app will host those resources. So as you can see, we've got for women, by women, and that's where these podcasts, these videos, these written materials will live. It's a digital one-stop shop for harm reduction resources. It holds the person at the centre, providing access to the support and information they need when they need it. But it's also a thorough resource for staff learning and development, and we want it to be a tool that's used widely across the sector when it's released. So also today, what's really special about being able to present today is I have one of the women with me, Jai, who has been such an integral part of the project. I'm going to play the sound and a couple of the voices of the women who've been involved in a digital approach to harm reduction and talk about what it's meant for them, and then pass you over to Jai.
Been feeling lonely for a long time, getting a phone, connected with my brother on Facebook. I'll be connecting with the rest of my family, so I've got a big family. Means the world to me, makes me feel good. Feels like there's a wee bit of hope coming, maybe.
Well, it helps me with my journal, my universal credit. Helps me contact my family if I never had my iPad. Also, it helps me to sleep as well. I struggle to sleep at night, and if I've not got my iPad or my phone, I don't sleep so well. So if I've had that, it's made me sleep really good, you know what I mean? And just for my workers as well, being able to talk to my worker every day and get outside support, which I really need, you know what I mean? What else does it do? I can go on my TikTok, play my games, you know. It helps with my mental health.
It means a lot to us because I've been in recovery now. I've got more access to connecting like online to things that help me in my recovery, because 5 months ago I was at my rock bottom. I picked the gas up again. Just thought this was it, I'm going to be in here and I'm probably end up dying in here, and something just made me basically pray to God and say I need out of this. So with online stuff, the staff looked up CA meetings and locally, and that's how basically when I'm on the tablet now I can look up CA. I can do my writing because I love to write. I've downloaded a thing on Aussie colour by numbers, that's quite good, so I do that. I do my therapeutic meditation on it, and I take my sleep insomnia because I've had insomnia ever since I came off meth the first time round. Like I can stay awake till like 4 in the morning, and then there's days that I can sleep at like 7 o'clock at night right through. So the tablet helps me do my meditation. My video calls are a lot more clearer now because that's 4G. I mean, my phone, the SIM card I've got with my phone is 4G, but it's only a 3G phone, so I need to get that upgraded. But I'm not really fussed now because I've got a tablet. I get to do video calls with my man that now, you know what I mean, and it's a lot clearer, and it's keeping contact with my family. But it's been a game changer because I can take it with me, you know what I mean, and it helps me like bond with my ma a lot more. I know she likes her games, and she's always funny about downloading them on her phone, so I'll do it on the tablet and we'll have a shot, you know what I mean. But it's just an extra helping hand, and it helps if like if I'm like it's mainly harm reduction, you know what I mean. But if my head's going 100 miles an hour and I'm like I want to use or whatever, I can just go through the tablet and look at either 24-hour like suicide things and that, and if no, I can just phone anybody that I've got for CA or workers or anything like that, so aye, it's definitely helped me.
Getting a phone or a tablet means that we can get on to meetings, we can get in direct contact with care managers and other healthcare professionals. It just eases so much stress and anxiety. It makes you feel human again, because the opposite of recovery is isolation, and isolation is not good for nobody, and having a phone or a tablet means you're connected again, and connection is power. We need more power, we need more connection, and that's what the digital approach to harm reduction means to me.
Thank you, Leslie. And I think, you know, listening to those voices and having the women's voices included there is really important, because we can hear the many different types of impact that it's had on people, you know, what connection can bring to us, what digital connection can bring is huge, and the wealth of opportunities in terms of getting someone through, you know, when they can't sleep at night to when they're in crisis and in need of mental health support. I just want to introduce Jai, peer expert for harm reduction, and Jai's with me just now. You heard Jai speaking there. So Jai has been such an integral part of the digital approach to harm reduction, and Jai wanted to speak here today about our involvement in the project. So I guess I would want to ask you, you know, we've talked a lot today about harm reduction in terms of the support needs for women, and you, what would you want people to know about your experiences of being a woman who has accessed homeless services in terms of high tolerance and low tolerance?
My experiences with being in services, I'll start off with the low tolerance services, because I've been in more of them than what I have been in high tolerant. Supported accommodations and emergency accommodation as well. I was in centre to begin with. That's where my homelessness journey started, and where it's carried on from, because once you're in this cycle, it's a never-ending cycle, and that's something that I wish for Scotland to get rid of, is that vicious cycle of being in homeless services day in, day out, month in, month out. The low tolerance services are very strict. They are very overbearing, especially if you're using, or if you have used and you've come in out your head on drugs or alcohol. Doesn't matter what it is you took. There could be big repercussions, which then alienate us as women, because we are, even though we are supposed to look like we can handle anything in the world, we cannot. This is just something that has been stereotyped from the early days of being a woman. We're made to look as if we're the glue, the strong bonds, but really we're not. We suffer from so much trauma. We suffer from so much, like, segregation, and in the 21st century as well, which is baffling. I cannot understand why us as women are still put in this category, that women are homebodies, women are this, women are that. I don't agree with it. And this is one of the driving forces behind the reason why us as women use the high tolerant places that I've been in, which has only been the one, which is the Simon community where I'm staying at the moment. It's helped me a hell of a lot throughout my journey. This time round, I've been in homeless accommodation. I'm able to go and ask for IEP and not feel embarrassed and not feel ashamed. I'm able to say to staff where I'm injecting into it and how much I'll be injecting, and if anything does happen, I've got the app there that Hannah was speaking on about, which has got the check on me feature, which is a huge burden off of my shoulders, because I know I can directly contact a member of staff and be like, I need help. Even if I can't move off my sofa, I can do it from my phone. And that's the thing that we need more in services. We need more check on me features. We need more things to guide women into having the knowledge and the support to be using drugs.
Amazing. Jai, what do you think, what are the next steps we should be taking in Scotland for women who use drugs? What do we need more of?
The next steps in Scotland, for me, as I would like to see, is education from a very early age, because from early age, I was 5 years old. That's when I had my first taste of cocaine. I'm not going to sit here and say I was X amount of years before I touched it, because that would be me lying, and being in recovery means that I need to be honest, and being honest with myself and honest with others. An education by primary school age to being 18-year-old in school, that'll give people a good knowledge, especially if they come from families who are in active addiction. It can show them the ways how to help their families. And another thing that I would like to see is women's only spaces in Scotland, because we don't have any. And this is a very, very scary thing, because we women, us as women, we bear children, and half the time we're in the toilet injecting, trying to hurry the process up, because we're no wanting to get caught, we're no wanting children to see us and stuff like that. Where if we had women's only places where we could sit and inject but still have children looked after, I think that is the main thing that we need as well in Scotland and in all over the UK, and by having women's only spaces for the likes of myself and so many other women out there to get knowledge on sexual health, mental health, and also getting help with our addiction and our personal care, which is centred for that individual person, because not every woman is the same. And for me, if I could help, for me, moving small hills to make mountains, that's that's where I'm at the moment. I'm moving these wee small hills to make mountains. So that means when I reach the top of that mountain, I know I can help somebody else create their mountain and help them up to the top of theirs. And that's coming from a place of empowerment. I would like to introduce a wee video that I made with Hannah. It's 10 tips on what you should know if you are a woman who uses drugs.
Thank you so much, Leslie, and everyone at Scottish Drugs Forum for having us. And just reading some of your comments, thank you so much to Jai for sharing today. I think it just shows, you know, the importance when we hear directly from the people that we support. So thank you so much for that. Thanks, Aileen.
Thank you, Hannah. That was fantastic. And thank you to Jai, because I think we're all a bit emotional and swept away by what you said. So well done. And if you have time to read all the, I think it would be a standing ovation if we were in a real physical space together. But there are lots of wonderful comments for you to read when you get a moment. So thank you so much. That was amazing. And again, just a fantastic example of the work we can do collectively when we work with people in that kind of production, co-design in a real sense, because I think those words are often bandied about, but they're not necessarily used in the fantastic example that you get there. So that was really good to hear. Thank you. So we'll come back to you for the question and answer, but we're going now to West to 8 hours earlier. So and calling Janice Abbott. Janice, are you there?
I am here.
Excellent, Janice. Thank you and welcome. Happy International Women's Day. Welcome to our session, and we're very much looking forward to hear of the fantastic Atira Resource Society. So take it away.
Good morning, everyone. It is early here, but not that early, a little after 8 o'clock. I am going to start by, I think, setting a bit of a stage. So there are just over 5 million people who live in British Columbia. It's a province that I live in Canada, westernmost province. In 2021, 2,224 people died by failed social policy or drug poisoning. That's up 26% over 2020. Of those 224 people, roughly 22% were women, and that's about 489 or 490 women who died by failed social policy. Since 2016, when this really kind of came to the forefront in BC, a little over 8,800 people have died by a failed drug policy. So that's the environment in which we're working. And I'll also share my bias, which is that I believe drug use is normal, okay, ordinary, whatever word you want to use, and it's social policies that create the harm, not drugs. So I'd state that bias from the outset. So I'm going to follow it sort of roughly. I don't often do slide presentations, but because I think they distract me, but I'm going to try and work my way through it. So I'm going to talk today about Sister Space and Sister Square, which are two women-only overdose prevention sites that we operate. One is indoor and one is outdoor. I'm going to share my favorite most powerful quote around harm reduction, which was put up by the City of Vancouver's drug policy advisor, Karen Ward, who is a close contact and collaborator with us. Harm reduction is a dynamic response to a fundamentally hostile world, not a set of practices to be learned and repeated, which can fail when institutionalized and removed from everyday life. It's an approach, a strategy of resistance that at its best can build justice and is love. And another one, harm reduction is not only about meeting people where they're at, it's also about loving people for who they are. Atira Women's Resource Society is a fairly large nonprofit organization. We have an annual operating budget of about $56 million. We're essentially a women's anti-violence organization. You can learn more about us by going to our website. But all of our services are organized around our understanding or belief that drug use is okay. It's social policy that's not, and organized around harm reduction values. So that's our residential programs, our programs with women and children. And one of our values is understanding that women's experiences of gender-based violence is central to their use of substances, and that understanding the intersections between women's experience of violence, poverty, racism, ableism, gendered patterns of drug use harms, and lack of support for mothering are critical to developing programs that are seamless and increase opportunities for women to keep themselves and their children safe. So one of our core values. And we also operate on these gender responsive principles that guide our work. So acknowledging that gender makes a difference is first and foremost. Creating an environment based on safety, respect, and dignity, and recognizing that safety equals consistency and predictability across time. So we're careful to be consistent and predictable. Women's lives are chaotic because of our social policies. And so our job is to not add to the chaos. We develop policies, practices, and programs that are relational and promote healthy connections to children, families, significant others in the community. We address struggles with substance use, trauma, and mental wellness through comprehensive, integrated, and culturally relevant programming and practices, and provide women with information and opportunities to improve their socioeconomic conditions, establish a system of comprehensive and collaborative community partnerships with other services. So those are the principles we operate under. We didn't develop these principles. We've begged, borrowed, and stolen them from other women's organizations and academics, but those are the principles under which we operate. So Sister Space was the first women-only community accessible overdose prevention site we opened. It opened in 2017. It took us probably 9 years to get this funded, and the funding is still not annualized. So we fight every year for enough funding and for enough funding to keep it open. At present, it's open from, I think it's 10 o'clock at night until 10 in the morning. So we're open during the times when 10 at night until noon. Open the times when women are telling us that they need it most. We hope to be open 24/7 eventually. We opened it in response to women sharing with us their concerns about using the all gender overdose prevention site. They talked about, not wanting to stand in line with folks that they owed money to, who had assaulted them, in the past week or the week before. Or abusive boyfriends in line. So there were a number of reasons that women didn't want to use the all gender space. They also shared with us that they found it very institutional. It's a typical, very effective, awesome program. So I don't want to take away from it, but women talked about it being sterile. So stainless steel, using booths which were stationary, screens between them. And so we really purposely set up Sister Space to look a bit like a kitchen in a living room. This is an early picture of it, not long after it opened. It's much messier now. So we wanted couches, we wanted a dining room table. We do have screens in the space, so women can drag a screen across if they want privacy, but very few women do. So the screens are almost never used, but it's set up like a kitchen in a living room. And women told us they wanted that kind of informality and the opportunity to spend time with each other. And so one of the other things in the all gender overdose prevention site is there's time limits on how long women could stay inside, and we don't have time limits. So we create space and opportunity for women to develop relationships with each other. And if you get a chance to read our most recent evaluation of Sister Space, one of the things the women talk about is how they've made friends. Both friends in Sister Space and friends at Sister Space, friendships that they maintain in the community. And that's one of the things that they report back on as being important to them, as well as peer staff. So Sister Space is basically harm reduction services for women who inject drugs. It includes staff and peer supported injection room, health education, access to treatment and healthcare services if women want, housing support, legal advocacy, and other related services. Women don't use the other services a lot. They're there if they're needed, but they're certainly not required. So women don't have to access anything. They can come in and use and leave, but they're there if women want them. As I said earlier, it's a safe, casual, clean, and supportive environment where women who use can inject their own drugs inside with other women who care about their safety and security. If they choose, they can connect to treatment and healthcare, but it's not necessary. We create a respectful and reciprocal relationships with women, recognizing that women are the experts in their lives, and the decision whether or not to make changes in lives are theirs alone. Some basic data: since Sister Space opened in May 2017, there have been 429,000, almost 430,000 visits and 430,000 injections, 138 poisonings, 233 doses of naloxone administered, and 33 emergency department transfers. So when you think about the number of injections and the number of poisonings, it's quite low. And that's because women are together. About 82% of the women who access Sister Space identify as First Nations, Métis, or Inuk. And we offer one-to-one support, although as you can see, the meals and the services are less important to women just by the sheer numbers than is the opportunity to use safely. Sister Space we've done a number of evaluations, including a developmental evaluation when it opened. And they're available on our website. They're worth a read. So Sister Square is our outdoor space. We opened it in 2020. It was part pandemic response and part a response to the increasing number of women who are smoking. Sister Space it's in an older building, does not have adequate venting for women to be able to smoke inside. So the tent offers that opportunity. We also have washroom, shower facilities, personal hygiene products, snacks, one-to-one emotional support, harm reduction supplies, and again, access to referrals. and it is open 24 hours a day, 7 days a week. This is a vet who's been working at Sister Square since it opened. What she wanted people to know is they're not broken, and we don't need to be fixed. So that's not the purpose of Sister Square and Sister Space. It's recognizing that women are whole beings, whatever's going on for them, and it's not our job to fix them. So women come to Sister Square. These are quotes from women who use the space, knowing it's a safe space for them. Whatever they're going through, we are there to help them in whatever way we can. The women help each other as well. For the most part, the bonds between women are strong. It makes a huge difference in women's lives to have a communal space like Sister Square, because most women feel empowered by social connections and relationships. So back to that principle of making spaces relational and creating opportunities for women to make friends. Personally, I think the success of the tent is that the women who come in for any reason, whether it's to use, shower, eat, hang out, are not alone. So again, back to the relational aspects of the space. The other thing we have to recognize is that every woman is different. Some come in just to clean up and use the bathroom, and some coming in ready to use with each other, or witness and watch out for each other's safety. And remembering that places like Sister Square are a work in progress. So it's our job to listen to the women who are using the space and make changes based on their experiences and feedback. And that's back to that original quote from Karen Ward about harm reduction being dynamic. So the drugs change, what women are using change, the risks change. We're now seeing in the last couple of days fentanyl in meth, which is new. So Sister Square and Sister Space have to be able to respond to those changes and the changes and the risk to women. And that's critically important if we're going to create a space for women to be safe with each other. So you can see from Sister Square that most women who use Sister Square are smoking. Again, 26 poisonings, 56 doses of naloxone administered, 5 emergency department transfers. About 75% of the women who use Sister Square identify as First Nations, Métis, or Inuk. And you see the number of women, individual women who use the space versus the number of injections and smokers, so which is important. And then before I wrap up, I'd like to talk just very quickly about some of the other things that we offer. So Maxine Wright Place, and we're building a new version of Max Wright in another part of BC, but it's a community health center, trauma-informed daycare, shelter, and second stage housing program that supports women who are pregnant and early parenting and who are also struggling with substance use and maybe fleeing violence or abuse. The goal of the program is to keep moms and kids together. And we have a number of programs where we focus on that because we know that roughly 81% of the women that we work with who are struggling with substance use grew up in the foster care system, and about 70% of them have children in the foster care system. So we see a relationship between women's lack of support for mothering, lack of support for parenting, the foster care system being taken away from your family, losing your kids in substance use. And so our goal here is to not have substance use be the reason that women are losing their kids, and hoping to prevent that intergenerational cycle. So everything about Maxine Wright Place is organized around keeping women and kids together. We have an OB-GYN who specializes in a substance use treatment. We have pediatricians. We stay connected to families until the kids are about 6 years old. We work with the Ministry of Child and Family Development, and we work hard to ensure that women can stay with their kids and kids can stay with their moms. We have a couple of post and pre and post treatment stabilization programs for women. Neither of them are abstinence based, so women are not required to be abstinents. We're just supporting them to reduce and or stop problematic substance use. So back to providing socioeconomic opportunities, safe, adequate, and affordable housing when we can find it, and support, mutual support between women. We have a similar program called the Veronica Block, specifically for First Nations, Métis, and Inuk women. All of these programs are staffed 24 hours a day, 7 days a week. And then finally, I'll talk about our shared using spaces in residential programs. So almost all of our residential buildings, and we have about 3,000 units of housing, affordable housing across the Lower Mainland, all of them where there is substantial substance use, which is most of them, we have shared using spaces. So these are rooms in buildings where we have a television and couch and harm reduction supplies, and where they're typically located close to the staff offices, so staff can respond, but they're often staffed by peers and residents in the buildings, so that people don't have to use alone in their rooms if they don't want to, and don't have to hide their substance use. So I think I'll stop there. As I say, you can go to our website and learn more about what we do, but yeah, I think I'll end there and answer any questions folks have.
Thank you, Janice. That was fantastic. And I imagine I speak on behalf of everybody to say we are deeply envious of the services that you have developed, and we'll like to hear more about them. So I'm going to invite Hannah and Jai to join us for this section of the Q&A, and then towards the end we'll invite the morning speakers in as well. I don't know, Janice, if you heard any of the previous, if you were able to hear any of the previous speakers, but I guess in Scotland we work within, you know, a context of prohibition in terms of that the almost impossibility, it would seem, of opening up overdose prevention centres for anybody. So that kind of limits the work. So we had some fantastic examples of work done and positive work done with women this morning and earlier before you spoke. But we have to operate within that context of drug use and overdose prevention centres being illegal. So I know in Canada you have come through a long journey to get to where you are now, and there was a lot of resistance, I guess, to the prohibition and to the banning of those centres. And is there anything in terms of advice? Because I liked your idea of harm reduction being a strategy for resistance. That very much appeals to the work that I do. And if you could talk to us a little bit more about that, and then there are other questions coming in, but I guess I'm interested in if you have any top tips.
So I think that in 2016, when it became really clear that drug poisonings were on the rise, we had a progressive Minister of Health in British Columbia. And I think at the end of the day, it's about having the right people in the right place at the right time, who are going to either turn a cheek or allow you to progress without punishing you. And so in late 2016 was when we opened up the shared using rooms in our residential programs, and we started opening them up kind of slowly across our programs. This was a request from residents, and we were seeing deaths in the building. People were dying in the rooms, dying of what we now call drug poisoning, not overdoses. And you know, it's important to remember and use language appropriately, because people are dying because they don't know what's in their drugs. They're not overdosing. They're taking unregulated, unsanctioned drugs. They have no idea what's in them, and so they know how much to use. They don't know what they're using, and so that's why people are dying. It's failed social policy, and we don't feel very lucky in BC, I have to tell you. We've lost a lot of people we care about across time, and we don't feel like the policymakers are moving quickly enough. We just open spaces, and including Insight, which was the first safe injection site, as it was then called, and waited to be called to task for them. And I think there's a piece of that. It's hard to do. It's a risk to take. We have an awesome woman named Sarah Blythe who just opened the overdose prevention site on a street corner, which is now funded. So it's those acts of resistance and sort of standing your ground that end up making a difference. And there's a lot of people who've taken a lot of risks here across time to try and help people keep themselves safe. And it's also a combination of lobbying, social media, lobbying, just doing what you think is right, irrespective of the consequences.
Thank you, Janice. That's fantastic. Leslie, how are we doing on questions from our virtual audience?
Great, we do have some questions coming in. So we've got a couple of questions that are all grouped around for Hannah and Jai around what will happen after the 12 months, more about how the devices got funded, and how will the women continue to be supported to stay connected. And then another question more around the provision of childcare at Sister Space and what happens if women come to Sister Space or Sister Square with children, and is there creche facilities provided?
Okay, maybe I'll go to Hannah and Jai first. So Hannah, going back to that issue about, so it was a 12-month project, the digital inclusion, which sounded fantastic, and we heard fantastic witnesses from the women about how much that meant to them. Do you have a sense of, because I think Janice mentioned funding as well as something that we all, particularly the annualized funding. So do we know what will happen?
I hope so. We've been really lucky to be funded within my post and within the digital approach to harm reduction by the Cora Improvement Fund, and we're looking to work with other organisations that do provide digital inclusion funding to continue this work. We know that it provides such amazing outcomes for the people we support and such amazing opportunities. We work really closely with Get Digital Scotland, who are connected to Simon Community as well, and we will have additional funding to hopefully supply more devices and get more women involved in the project through that. You know, it's unfortunately it's a shame that we have to work to these funding parameters, because we can see the incredible work that's happening, but I just really hope it can continue.
Yes, so do we. Yeah, because it just sounded like it had a fantastic effect on people's lives, and that idea of connection, which I think Janice mentioned as well, about, I suppose before it used to be, you know, that knowledge is power, and now it seems to be that connection is power, that being able to keep connected and keep informed and share knowledge, particularly amongst women, because that's the way we work. We like to work collaboratively. So that would be great. Janice, so that question about for women with children in the services, are they specific examples of good practice for how you work with women with kids?
Yeah, so as I saw the question pop up, and I'm trying to think whether or not we've ever had a woman with a child show up at Sister Space or Sister Square, and I don't think we have. So I can't speak to that. And if a woman did show up with a child, there's a couple of things I can say for sure. We would not automatically call Child Protection Services. We would, our staff would support the child and maybe take the child for a walk. I don't know, depending on how busy it was in the space. So, but one thing we would not do is call Child Protection Services at all. At Maxine Wright, where we do work with children, we have, as I say, we have the daycare, 58 space daycare, trauma-informed daycare. So we really encourage women to give themselves a break and enroll their kids in the daycare. It's $10 a day daycare, so it's inexpensive, $300 a month. And access services in the community health center where there is childcare provided, and groups for kids and activities for kids. So we really try and organize the day around providing women with some space, activities for their kids, a chance for children to talk about substance use in their family and how that has impacted them, and support for the family as a unit, and working closely with social workers to ensure that social workers who can be still be a bit behind the times aren't apprehending solely because of substance use.
Thank you. Thanks for that. Leslie, any more questions coming in?
Yep, there are. So other questions around what happens for specific situations around Sister Space and Sister Square. So is there any specific examples you can give on what happens in terms of if someone's involved in the criminal justice system, do police get involved, courts, for example, and also sexual health services and sexual health information around HIV, other bloodborne viruses, STIs, reproductive health for example?
Yeah. So good questions. Many of the women who use Sister Space and Sister Square are also doing sex work. So yes, there's a focus on sexual health, including the provision of sexual health supplies and information. We have a nurse practitioner and a nurse who is available a couple of times a week. And so women can get OBGYN exams and access to sort of primary health care if they need it. And in particular, if they're unwilling to go to a typical healthcare center, which many are because of medical racism or how they've been treated by the healthcare system. And with respect to whether women involved in the criminal justice system, we don't ask. So it's irrelevant to the services we're providing. So we don't ask women. And, you know, I guess it's never happened. I guess it's possible that someone could come in and the law enforcement could arrive and sweep them away. It never has happened, but we don't ask.
And a final point, I think it's Jai here's got our testing facilities available within the services, so to test the drugs.
Yeah, we have testing strips available. Not 100% of the time. It depends on, we've had supply chain issues like everywhere else in the world since the beginning of the pandemic. But when we have them, they're available. And we also have a lot, one of the really amazing things about having women-only spaces and having them staffed by peers and the women themselves is there's a ton of information sharing. Women who are using drugs know when bad stuff is going around. They typically know what it looks like, what the packaging is. So, and it doesn't necessarily mean they don't use it. It's just that they have systems in place to keep each other safe when they know bad drugs or poison drugs are circulating in the community.
Good thinking. I think there's a nice question there about what services would you like to see in the future in British Columbia? So given that you are ahead, if you like, of the posse of where we are, where would you see yourselves growing and the things that you would like to see improved?
So what I'd like to see is an end to prohibition. That's where we're going. Baby steps though. So the city of Vancouver has applied to the federal government and just how our parliamentary system works in Canada, but has applied to the federal government for an exemption with respect to criminalisation. So we want to become a decriminalised city so that drugs won't be taken from dealers or from, because one of the biggest issues that happen is when drugs are seized. And we already have a short supply and drugs that are significantly adulterated because of supply chain issues related to the pandemic. And so when drugs are seized, it increases risk for everybody. So moving towards a decriminalized city is really important. And then after that, an end to prohibition. I'm not sure that will happen in my lifetime, but that's definitely a goal. We are working, so there's a couple of other sort of things we have in place. So we're involved in a pilot program with a program called MySafe, and in 2 of our residential buildings we have vending machines. So using biometrics, people can come down and get a dose of it. We're looking forward to have diacetylmorphine. Right now it's dilaudid. They put their fingers up, they get their dose of out of a vending machine. So we've got about 100 folks who are signed up and using vending machines as a way to get their doses every day. We'd like to expand that program. And more importantly, we want to set up a cafe or a bar or something with vending machines so that people don't have to have it in their homes. They can go get a cup of coffee or a glass of beer and a snack and go to the vending machine and get their dose. So that's a project I'm working on with Karen Ward, who I quoted in my slide presentation. And we will set that, we're just going to set that up. We're not going to ask permission for that one. We're going to get it set up and dare them to shut it down.
Fantastic. I like your style. They are such, fantastic ideas for us to think about and reflect and hopefully resist our current system. Any further questions, Leslie? Are we?
None have come in. I have one. There was a question earlier on, Janice, around the provision. We don't provide crack pipes within Scotland to women who use, or anyone who uses and smokes crack. What's the range of equipment that you provide in your services?
Yeah, we provide crack pipes for sure. We provide everything we can get our hands on. So, and, you know, at Sister Square, as you saw from my slide, the vast majority of women who access Sister Square are smoking. So we have harm reduction supplies for those women.
Brilliant. Thank you.
So really just last chance to get your questions in, folks, if anyone has any questions. But over to you, Aileen.
Thank you.
I want to say too, is I'm not sure what the status is in Scotland, but we're seeing a real move away, a trend, so a move away from injection drug use to smoking. And so we have to be able to pivot with that if we're going to, again, create space for women to keep themselves safe.
Yeah. I don't know if that trend happens here, but as it happens, I'm involved in a study that's just about to begin, which is looking at smoking strategies, if you like, by people who use drugs. And we know that people can pick up, for example, foil in our needle exchange programs. We're not quite too sure what happens and what it's been used for. So it's a very much a kind of harm reduction research project, just trying to understand what smoking is or not among people who use the services and what we can do to support them if it is. I suppose I wanted to go back to, because I teach a module on the politics of drug and alcohol policy, and we look at the situation in Scotland, but also in other countries, and how it's such a politicized issue. And Janice, you mentioned, you highlighted it as a bias about social policies being more harmful than drug policies, and I share the same view, but I would say it's evidence-based. It's not just a bias, it's an evidence-based that we do know that what we call structural violence from social policies it does enormous harm to people, and particularly to women, and particularly to people who use drugs, and provides the kind of risk environments where drug use becomes more harmful and problematic when we have very poor social policies. So for me, one of the issues that kept coming up in all the speakers, and I invite back the speakers we had this morning to join us for maybe this one, about how social policies have really engineered unsafe environments for people, and particularly for women. You know, we think very much about poverty and cuts to benefits, and you know, the lack of availability of decent housing and health inequalities that are you know, Alison mentioned in her talk this morning, you know, there's a 25-year difference in terms of life, a healthy life between women who are poor versus women who have more economic and social resources. So in terms of how we address those things, I suppose this is maybe me hijacking the discussion for a little bit, but in the absence of other questions, maybe are other people, you know, do we see that in the services? Because I think everybody who has been talking has talked about how, you know, the substance use is one issue, but the broader social issues are really loom large and influence the outcomes for people who use drugs and the outcomes of their being able to access services.
So I think there are a couple of things you said there that are really important. We know that the consequences of drug use are much different for women who are racialized, women who are poor, women who have trauma in their lives. Women with resources get babysitters. They have family to support them. So the repercussions for women who are poor, women who are racialized, women who are disabled are significantly higher than for everybody else. And that's another example of failed social policy. We also know it contributes to death rates for women who are poor. And that women who are poor, who use drugs, tend to be less connected with the healthcare system. So they die not necessarily by drug poisoning, but by just failed social policy, or death by 1,000 cuts of injustice really is what it ends up being. So there's a whole piece packed up in here. And we know that drug policy as it stands is also based on racism as well. And around the world, and you know, we can trace it in Canada. So it's really death. You know, when we think about drug poisonings, we think about death by 1,000 cuts of injustice.
Yes, and I think in Scotland we have quite a sort of a narrow definition of what constitutes a drug death, which kind of excludes a lot, particularly deaths that might be related to violence against women who use drugs. But also there's always the focus is put on the drugs that people took and the drugs that are implicated in the death, and not so much focus on, as you say, the broader social issues that people face. And you know, I think the good examples, the fantastic examples we had from the Simon community this morning about their practice was that they were reaching all those parts. So yes, working with women around their substance use, but doing it in a way that was co-produced and co-designed with the women so that the services really responded to those needs. And I suppose earlier on I had used the term, you know, gender responsive services. And I think what we heard were really good examples of what those kind of services could be in addressing the specific needs of women and looking at that broader context of substance use just being one aspect of the many things in their life experience.
Aileen,
well, how are we? Yeah, Catriona, please.
Sorry, just briefly, just on that point, really, just to point out from our recent drug death stats and an Audit Scotland report today, yet again highlights that women in disadvantaged, the most deprived communities in Scotland are 18 times more likely to die a drug-related death, using that narrow definition, than people in the least deprived. So, you know, that's a very stark statistic, I think, that we all need to be aware of. And this has been increasing, that gap has been increasing over the years alongside this escalating number of drug deaths. And I think if we looked more broadly at drug deaths related to drugs, not specifically, you know, that toxicology definition, we might find that was even more apparent. I don't know that for sure. I'm just saying that's my hypothesis. So, yeah, it's very stark, I'm afraid.
Yes, I mean, one of the research pieces I'm working on at the moment is about a social autopsy of drug deaths, that trying to look at the broader picture of, you know, what was happening in people's lives prior to their death, not just in the, we have some data about, you know, 3 months, 6 months before the death, but trying to trace backward through people's lives to identify the kind of structural violence and the trauma that people have experienced that led up to the death, really.
There's an interesting question in there that how has transgender inclusion affected service provision and support for women? And I'd like to respond to that because it's something we're struggling with at the moment. And not so much around transgender women, but around the increasingly fluid ideas of gender. So in some ways, transgender women are easy, and I don't mean to be sort of flippant or dismissive about that. Our services are inclusive of transgender women and have been since the late 90s. But as we see gender identity become way more fluid, we're really struggling with how to be inclusive and still keep women safe. Because misogyny and transmisogyny are still things in the world. And so it's a conversation we're having and we haven't quite figured out yet. So if whoever asked that question has any ideas, I'm all ears.
Thank you, Janice. It's a very topical question in Scotland at the moment as we're going through the change around the Gender Recognition Act and people being able to self-identify. And yes, that I think it's an ongoing discussion, isn't it? But really interesting to hear that since the 1990s that your services have been open to transgender people. So that's really interesting to hear of that.
Transgender women. Sorry, what?
Yeah. Yes, tiredness will be the excuse of if I'm not so coherent. So I think we actually are drawing towards the end. We had.
Can I just come in and just ask Hannah, Jai, at one point in the chat, Jai, you said that you wanted to come in and answer a question. Don't know if Jai, you're still there and you still wish to respond to a question?
Yeah, I'm still here.
Thank you.
The question was about the yes, with the provisions of crack pipes, me personally, I would like to see that rolled among every service in Glasgow, not just women's services, because for us who are moving away from heroin use, we're moving more towards cocaine and crack cocaine again, and this is an epidemic that has been going on for quite a while now. And how can we smoke crack if we're not allowed to have crack pipes? No, it's baffling me at that point, and plus it will baffle everybody at the fact that, yeah, harm reduction is going and smoking a bit of crack instead of injecting it, but we're not in that frame of society where we can freely have a crack pipe, or in my case, I smoke marijuana. I'm not going to sit and say I'm totally clean or I'm in any sort of way, but the laws around marijuana needs to change as well, because as marijuana smokers, that's harm reduction to a T. If you're not using high illicit drugs, and if you're only using marijuana, that is harm reduction in itself. And I would like to see that getting rolled across Scotland as well.
Thank you, Janice. Oh, sorry, on you go.
And with testing facilities in Scotland as well, I'd like to see that happening, because if we can get our drugs tested and knowing what's in our drugs and knowing how strong they are, then we know the correct doses that to get the perfect high but being safe at the same point.
Yeah, I think they're really good examples, Jai. And I guess one of the things at the end of today was we were thinking about, how do we harness the energy of, over 500 people registered for this event today, and what can we do next, and where can we take a lot of the good practice, but also, the issues that we need to be addressed. And I think, Jai, you've set 3 tasks for us. One about the provision of crack pipes, looking for whether it's medical marijuana use or decriminalized cannabis use. That you've set 3 tasks for us there that we could start beginning to work on those and use harm reduction as that strategy for resistance that Janice talked about. So I would really like to thank all our speakers. Fantastic presentations from everybody. Really heartening on International Women's Day to hear of the positive things happening, because there's so many dreadful things happening. And I suppose we think of our sisters in Ukraine today and other war conflict sites and remember them. But we think also, because we have to move forward, to think of positive things that are happening and things that we can do. So thank you to all our speakers. Thank you to everybody for coming in today. And a very special thank you to Sophie and Leslie and Lisa. And thank you to Leslie and Scottish Drugs Forum and the Simon community for coming up with this idea. It was fantastic. And let's do it again. Have a good International Women's Day to everybody. And thank you.